So now we will proceed to the next segment before lunch, the Global Forum. Chairing this session are Professor Tilak Jayalath and Professor Krishant Jayasekar. Please welcome them on stage.
Good afternoon. Welcome to the Global Forum. We have two eminent speakers from India. And first we start with Professor Nandini Chatterjee. She is currently attached to the Institute of Postgraduate Medical Education and Research in Kolkata. And she's a very active member of API, and she's known to many Sri Lankans. And I must tell you that she has been working very closely with our college for the last several years. So we'll invite Professor Nandini Chatterjee to talk on chikungunya arthritis, an important differential in the management.
Thank you very much, sir, and a very good afternoon to you all. I'm especially thankful for Dr. Shuranga for inviting me here to Sri Lanka, and it was very great to catch up with old friends like Dr. Kumudini and Madhuvanti. So today, I'll be discussing on a topic which is less highlighted, but is becoming more and more important because we may miss this diagnosis. So let us begin with a case. We have a 20-year-old male with a history of high fever for 6 days with severe pain in joints along with headache and backache. And we examine that person and find that he has a temperature and swollen tender joints like the wrists, ankles and fingers. He also has maculopapular rashes on his trunk, extremities and face. The rashes are pruritic. Now, when we encounter a patient who has an acute onset of polyarthritis, usually we will be considering some of the crystal arthropathies or maybe a reactive arthritis, or we'll think that that person has an exacerbation of collagen vascular diseases. However, we must keep in mind a whole bunch of etiologies which are infections. They may be viral, bacterial, and also protozoal. Coming back to our patient, we must remember that our patient not only had polyarthritis, but also had rashes and fever for the last 6 days. So in this scenario, from the long list of diseases, we were thinking that maybe we were dealing with an infection. So again, this is very difficult because infections are also multifarious, which can cause fever with joint involvement. Dengue, chikungunya, Zika viruses, many other viruses, including HIV, EB virus, cytomegalovirus, all have been known to cause joint pains along with the fever. We should not also forget bacterial causes as well as malaria, scrub typhus, leptospirosis. The last one that is written is a great mimicker. Therefore, SLE should never be forgotten to be considered in this long list of causes. So, what did we find when we investigated our case? Her complete blood count was normal, but the ESR and CRP were raised. When we did the dengue and the malaria tests, they came out to be negative. The scrub typhus IgM antibody was also negative. Now, because chikungunya has become endemic in our country in the last few decades, so we then did a serology for the chikungunya infection. Anti-chikungunya IgM became positive. Coming to my second case, we had a 53-year-old lady who presented with pain and swelling in her wrists, ankles, and hand joints for the last 4 months. She also complained of a morning stiffness over 1 hour with fatigue and generalized body ache. And when we examined her, we found that there were tender, swollen ankles, wrists, and also the metacarpophalangeal and proximal interphalangeal joints. We also inquired whether there was any history of fever or not, and we found that there was indeed a history of fever with chills along with rashes, which had subsided 4 months ago, being present for about a week. Now, in this second case scenario, what will we think when a middle-aged lady, comes with pain in the small joints of the hands? So, of course, we'll be considering whether she's suffering from rheumatoid arthritis or SLE or any crystal arthropathy, or whether she has a spondyloarthropathy with a peripheral involvement. But again, as I said, we should not forget the infections. So, infective endocarditis, tuberculosis, and even CHIKV arthritis, that is chikungunya arthritis, should be kept in mind. So, what did we find when we investigated her? Again, her ESR and CRP were raised, but her uric acid levels, the RA factor, the anti-CCP, and the ANA all were negative. MRI of the ankle and wrist joint was performed, and there was effusion, marrow edema, and synovial thickening. But because the autoimmune profile was negative, we went for a serological test for chikungunya, and it became IgG positive. Now, these two cases are just illustrations of the two types of presentations of chikungunya arthritis that we can come across. The problem is that there is no single test or clinical presentation which is suggestive of viral arthritis. The diagnosis needs a strong clinical suspicion along with some tests which will help you to exclude other diagnoses. We can suspect a patient to be having a viral etiology if the duration is less than 6 weeks and if the joint complaints are associated with rashes or fever or lymphadenopathy. Also, we must take history of whether the patient has traveled in the recent months prior or whether the patient is having a drug dependence or they are lab workers. Now, will we ask everybody to do a test for chikungunya? We will not. Firstly, the presentation is important, and secondly, what is extremely important is the local epidemiology. What is true for Indian patients may not always be true for the Sri Lankan patient. So it is important whether this disease is having outbreaks or is common in your locality or your country. In that case, you definitely should go for the test. And as I said, that this is a diagnosis of exclusion, so we need to do the other inflammatory markers and the autoimmune profile if we are dealing with a case of a chronic arthritis. Now, a few slides to discuss about the spectrum of this disease. Now, chikungunya was first encountered in Kolkata in around 1963, and after that it became quiescent. There was a re-emergence of outbreaks after 2005, and now the scenario is very grave because after 2005, for the last 20 years, this disease has spread out like wildfire, and it is affecting both the tropics and the temperate zones. Human beings are the primary hosts, And there is a vector, a mosquito vector, which can bite that infected patient in the acute phase and spread the infection. It has also been said that laboratory assistants or healthcare workers can rarely have blood-borne transmission. The classical vector is the Aedes aegypti mosquito. But as in the case of all other viruses, due to mutations, now the vectors are also changing, and the Aedes albopictus is another mosquito who has taken up the mantle from Aedes aegypti, and it is now spreading the infection in various temperate zones as well. And as we all know that international travel and migration is a great culprit in the spread of these tropical infections to various countries. Now, the presentations, they can be acute, post-acute, or chronic. The acute infection is just like the case that I described. There is high fever, there is maculopapular rashes, and joint pain or even joint swelling involving both small and large joints. There can be a post-acute phase which can go up to even 90 days. But most patients have a self-limiting disorder which is over by 2 weeks. But there are unfortunate individuals who can develop a chronic chikungunya arthritis, which is very distressing and debilitating. So these patients will have arthralgias, even arthritis, beyond 3 months. It can even go up to 2 years. In addition to the joint pain, they may have tenosynovitis, tendinitis, and even neuritis has been reported. Another thing that happens is that they have exacerbation of their comorbidities, and they may even have exacerbation of their osteoarthritis. So how to diagnose? Firstly, there can be a suspected case, a patient with fever, with joint pain or swelling which is persisting for weeks. Also, that person may be having a history of travel, and you can confirm it either by a RT-PCR, a serology, and if it is available in your center, by viral isolation. But that will happen only in the acute phase. The commonest way to diagnose that we are also doing, that is the serology. For acute cases, the IgM antibody will be positive, and for the chronic ones, then you can have IgG positive. Another way of confirming an acute infection is to do paired sera, and if there is a 4-fold rise, then you know that the person is suffering for the acute illness. The chronic arthritis is more common in middle-aged women, and as I have already mentioned, the joints that are usually involved, the inflammatory markers will be raised. And the problem is for you to exclude the other causes of chronic arthritis. And to add to your problems, chronic chikungunya arthritis can have a positive rheumatoid factor, and sometimes, rarely, they can also have a positive anti-CCP antibody as well. So there have been instances that chikungunya arthritis patients have been mistakenly treated as cases of rheumatoid arthritis. The MRI findings, as I have said, they also mimic the chronic autoimmune diseases like rheumatoid. So there may be synovial thickening, even bony erosions may be found, and marrow edema. Another problem that can arise, that is in the case of acute arthritis, is that dengue virus, Zika virus, and chikungunya virus, they have similar or overlapping clinical findings. In view of this, I would like to share with you a third case. This is a 30-year-old man who presents with high fever, headache, and joint pains involving both the small and large joints. The patient also had dizziness on standing and developed rashes all over the body on the 6th day. And the photographs shown here are the rashes that developed in this patient. Well, I think you have guessed what he was suffering from. He was suffering from dengue. And he also developed effusions and ascites later on. So this comes to the discussion that how to differentiate maybe, or at least think of differentiating between chikungunya and dengue, as well as Zika. Zika virus is not so commonly diagnosed in our parts of the world as well, or maybe we do not test for it, so we don't know. But all these three viruses, they are coming with fever, rash, and joint pains. However, it is said that more than arthritis, dengue and Zika are causing arthralgias. If found in a pregnant patient, the Zika virus can also cause many teratogenic effects like microcephaly and fetal loss. So I am not going to go into the details of this table, but what I must point out is that in the case of dengue, presence of shock, bleeding manifestations, and the extent of suppression of blood cell lines is more than the cases of chikungunya. So how to treat such patients? When acutely presenting, basically your treatment will be symptomatic and supportive. You give rest, fluids, analgesics, and in dengue endemic areas, we know we'll go for the acetaminophen as the first line. However, if your patient is having persistent joint pain, then the treatment regimen is slightly different. So apart from the supportive therapy, and when you have failed to give relief to the patient and the thing is going on for 2 weeks or 3 weeks, then you may consider giving a course of prednisolone. This has been said that if you give a month-long course of prednisolone in low dose, maybe 5 to 10 milligram per day, it has been seen that the patients respond favorably. Sometimes you may also need to give those patients amitriptyline or gabapentin to relieve the continuous aching. Now, chronic arthritis, where the patient is having arthritis beyond 3 months and your analgesics are not giving so much of relief, in that case, the treatments have been carried out by various trials, and the treatments actually resemble the therapy usually given to rheumatoid patients. So hydroxychloroquine, 5 milligram per kg per day can be added along with the analgesics. If your patient is not responding well with only hydroxychloroquine, then you can also give a combination of hydroxychloroquine and sulfasalazine. Later on, a weekly methotrexate has also been added in many cases with good results. There is also always a way to prevent these infections rather than trying to treat them, and community level mosquito control programs and personal protective measures are extremely important. There is a single live attenuated chikungunya vaccine also available, but it is not for everybody. There are specific recommendations of travelers to areas with outbreaks or endemic for chikungunya, where this vaccine can be given to the adults or to the people who are going to stay for a longer period, like 6 months in an endemic area, especially those who are elderly and having comorbidities. So, thank you.
Thank you, Professor Chatterjee, for enlightening us on chikungunya arthritis. We'll leave the questions at the end of the forum. May I invite the second speaker? It's my pleasure to invite Professor Jyotirmoy. I think he's a very good friend of the college, and he's a fellow professor in general medicine, and he's the Dean of the Indian College of Physicians. Over to you, Professor Jyotirmoy, to discuss on extrapulmonary tuberculosis, an expert's view, which is a disease which is commonly shared by both countries. Over to you.
Thank you. I am very much delighted to be invited by my good friends in Sri Lanka, the country which has a relation with India for more than 3,000 years. The disease, a topic entrusted on me, almost have common presentation in this subcontinent, India, Bangladesh, Sri Lanka, Nepal. And the evidence of tuberculosis is even found in the Egyptian mummy, which is around 3,000 years back. Till now, world medical fraternity, in spite of our all-out effort, we fail to eradicate the tuberculosis. Rather than we are facing new challenges in diagnosis and management of tuberculosis. Briefly, now we'll discuss what are the challenges we face in diagnosis of tuberculosis, and particularly in the extrapulmonary tuberculosis. That is a more challenge than diagnosis a pulmonary tuberculosis. Let us see two index cases. First case, 40 years male, came with history of low-grade fever for 3 months, cough of almost same duration, have a sputum, weight loss, and such type of X-ray. What is the most probable diagnosis? It is very easy for any topical physicians. Such a low-grade fever, cough with just the infiltration in the right upper lobe, most likely diagnosis is the pulmonary tuberculosis. And what investigation we said? Commonly we send for the sputum for AB staining. And if we get, we start treatment. But challenge is the case number 2. He is a 23 years female. He has a recurrent abdominal pain for 2 years and intermittent pain for fever for almost the same duration. She was admitted several times and investigated and discharged with different type of medication, maybe PPI and others. Lastly, he was admitted with a similar episode, pain, vomiting, fever, and mild abdominal distension. This time, the patient was undergone imaging, that is a CT scan. And CT scan, such type of imaging has been found. So what is the differential diagnosis? It can be amoebic liver abscess, it can be pyogenic liver abscess, it can be hepatic malignancy or hepatic tuberculosis. So what is the challenge here? Challenge here to create difficulty in getting the tissue, because liver biopsy facility is not available apart from the tertiary care center, mostly in the primary and secondary care center. Also, often such type of patient has an altered PT-INR, an abnormal liver function test. So, physicians are very apprehensive to get a tissue or do a needle biopsy for the fear of bleeding. And even if you diagnose the tuberculosis, challenges in presence of how I will modify the drugs in presence of abnormal liver function. So this is the challenge. Day to day we are facing the physicians in this tropical country to diagnose and treat a extrapulmonary tuberculosis. So what is the challenge and what is the difference in diagnosis primary versus pulmonary versus extrapulmonary? In pulmonary, there is a mainstay of diagnostic tool is the sputum. We can send for the culture or AB staining. But extrapulmonary basically possibacillary in nature. So that is why we cannot take the sputum so easily. We cannot get, so very difficulty to get the tissue and to establish that it is a case of tuberculosis. This is the statistics. In the pulmonary tuberculosis, by a good microscopic, you can detect the AFB in sputum in more than 50% cases, maybe even up to 70% cases. But if the pathologist or the technologist has a expertise in this field. But in case of extrapulmonary cases, lowest the abdominal TB, it is a 28 to up to 40%. You see, whatever may be, it is very difficult to get above 30 to 40% cases the AB positivity. So that is why without getting the AFB positivity, the extrapulmonary cases to stamp the case of the extrapulmonary tuberculosis, it becomes difficult and difficult day by day. So what are the diagnostic modality we use? One is the FNABC, one is the culture, analysis of the body fluid, and different molecular technique. That's the four mainstay of diagnostic modality to establish the disease. But remember, even if patient has come with suspected abdominal tuberculosis, CNS, skeletal, whatever may be, always ask whether patient has a cough. If the patient has a cough, even if your primary diagnosis is the extrapulmonary tuberculosis, maybe skeletal tuberculosis, send sputum for the AFB staining. If the positivity comes, your diagnosis is very easy. You can stamp the patient as the patient is suffering from tuberculosis. So sputum examination is must. So coming in brief of the standard methodology, one is the ZN staining. ZN staining, I told, by expert microscopic, in more than 50% cases you can diagnose very easily, and sensitivity can be increased up to 80% by using the fluorescent microscopy. So this is the very commonest investigation used all over the world. Second is the biopsy. Biopsy, very classically we have learned from the third year on pathology training, is the epithelial granuloma with the caseation necrosis, highly suggestive of tuberculosis. But there is two challenges. One challenge is, in case of immunocompromised patient, we may not get the suppuration, rather than we will get the suppuration rather than the caseation. And in some other condition, similar pattern we get, such as sarcoidosis, brucellosis, non-tuberculous microbacteria, histoplasmosis, almost similar pattern we may get, and we may be confused. Culture is the gold standard, but facility is not available everywhere. Advantage is, there is one limitation, one advantage. Advantage is, even if there is 100 bacilli, you can get the culture positivity. So for the ZN stain, minimum microbacteria should be 10,000. For the culture, it should be 100. And by culture, not only you can detect the bacilli, you can get the sensitivity pattern. That is very important in the era of multi-drug resistance tuberculosis. But limitation is the timing. Usually by the standard media, it takes around 4 to 8 weeks. But in the liquid media, bacterial culture, we may get by 7 days. But again, disadvantage is facility is not available in every places, and we cannot use very routinely. Analysis of the body fluid. In extrapulmonary, almost this is become a routine practice to analysis of the body fluid, and usually we get an exudative and lymphocytic predominance nature. But remember, neutrophilic leukocytosis does not rule out, because in the early phases we get the neutrophilic leukocytosis. Later on it turns to be the lymphocytic predominance, cob wave formation. And last line is very important. If you get the more than 10% mesothelial cell, almost virtually rule out the tuberculosis. And ADA, another very commonly we use ADA. ADA is a high level of ADA is specific, not specific for the tuberculosis. It suggests, because ADA basically is a lymphocytic product. So those diseases who use, where there is a lot of predominance of the lymphocyte involvement, we get the high ADA. So there are other diseases such as lymphoma, rheumatoid arthritis, and parapneumonic effusion, where we can get the high ADA. So that is why ADA is very sensitive, highly suggestive for tuberculosis, but not specific for tuberculosis. So this is the cutoff values done from the different study in this tropical countries. In pleural effusion, it is more than 40. In meningitis, it is more than 9 or 10. And cirrhosis of the liver with ascites, more than 27. It is highly specific and sensitive, near about 100% of suggestive of tuberculosis. So there are other method out, I told, there is a molecular method. One is the PCR technology and CBNAT. This is highly sensitive. Even presence of 10 bacilli, you can get the CBNAT positivity. So for the acid AFB staining 10,000, for the culture 100, and for CBNAT it is a 10 bacilli, minimum 10 bacilli is required. So we are coming to CBNAT. This is very popular nowadays in India, because very quickly, by 2 hours, you can get the result. And we can very easily, you can detect immediately the rifampicin resistance, because two resistance is very common in this subcontinent. One is rifampicin, one is the INH. And sensitivity usually varied above 80% except the pleural effusion. So pleural effusion, though you use the commonest extrapulmonary tuberculosis, is a challenging to us because we often send the pleural fluid for the analysis. We get the lymphocytic predominance, high protein, ADA high. But for CBNAT, its sensitivity is very low, around 40 to 45%. That is why if you think that it can be a tubercular effusion and CBNAT is coming negative, your suggestion is send the repeat CBNAT, even maybe 1 or 2 times more. If finally highly suggestive and you have to stamp not willing to give the empirical therapy, you have to go for the pleural biopsy. That issue I will come later on. So pleural effusion CBNAT is a challenge. Line probe assay, initially it was approved by government India only for the sputum positive cases, but now it is approved for the sputum negative even in the extrapulmonary tuberculosis. Here advantage is 2 resistance you can detect. One is INH, one is rifampicin. But CBNAT only 1 resistance, that is the rifampicin. Molecular testing, tuberculin skin test owns maybe 50 years back, it has a high importance, but nowadays we do not give much importance to tuberculin test because tuberculin positivity means patient have infection, and tuberculosis disease and infection is different. It cannot differentiate whether patient has a present infection or past infection, except in some of the cases like undernourished, elderly, immunocompromised, or before giving some of the therapy. This tuberculin test has lost importance nowadays. Gamma interferon, I don't know what is this country, but from 2012 it is not approved in India because EGRA positivity means, again like the tuberculosis, means there is a infection, does not mean there is a disease. So that is why it is banned in India. Antigen detection not popular in this subcontinent. Imaging is not diagnostic but very much suggestive. So whenever you are thinking patient may have some extrapulmonary tuberculosis like pleural effusion or constrictive pericarditis or abdominal TB, go for the USG, CT, MRI, whatever is applicable in that case. And that give a lot of clues that patient may have the extrapulmonary tuberculosis of that organ. So TB can affect every organ of the body. So just I have picked a few of the extrapulmonary tuberculosis. One is lymph node TB, pleural effusion, CNS tuberculosis, abdominal tuberculosis, skeletal, renal, urinary, TB, pericarditis, ocular. So many extrapulmonary TB tuberculosis can be discussed in the whole day. But I will give some of the highlights. What are the challenges in some of the extrapulmonary tuberculosis? TB lymphadenitis is not very difficult to diagnose, particularly if there is a peripheral lymph node, because we can do either FNABC or we can do the excision biopsy, and we can send the patient for staining, we can send the patient the histopathology for the culture and CBNAT. So we can much easily can diagnose the TB lymphadenitis if there is a peripheral lymph node. But challenge is if there is a mediastinal lymph node or retroperitoneal lymph node because of the accessibility, and need a expert radiologist to get the tissue from that particular zone. Tubercular pleural effusion, I told challenges. We usually do the high ADA, and if ADA is more than 40, it is highly suggestive of tuberculosis. And CBNAT, here sensitivity low. That is why repeated aspiration may be required. And pleural biopsy done in the highly suspicious cases. Even if patient is suggestive of tuberculosis, but the other allied test does not give the confirmatory diagnosis, we should go for the pleural biopsy rather than giving the empirical therapy. And in tubercular pleural effusion, often missed in a patient with recurrent pleural effusion. That is the challenge of the recurrent pleural effusion, because we often either treat some other disease, miss tuberculosis, or treat the patient with antitubercular blood, but later on it is proved to be some other disease like the collagen vascular diseases. This is the one case. So this is the guideline pleural effusion. The exudative nature, pleural fluid, ADA is more than 70, start ADT. If the age is between ADA is more than 40 to 70, but if the age is less than 40, patient has a prolonged fever, patient other diagnosis is unlikely, and start ATT. But if there is no response by the 4 weeks, go for the pleural biopsy. If ADA is less than 40, you think of the other disease and do not give anti-tubercular drug empirically before doing the pleural biopsy. So this is the protocol that we follow in case of pleural effusion to diagnose tuberculosis as the etiology. CNS tuberculosis is again the analysis of the fluid along with the ADA. Usually if ADA is more than 9, it is highly suggestive. Culture is the gold standard, but again the facility is not available. This is the situation. There are only few situations. Nowadays we discourage the empirical therapy, but there are few situations where the empirical therapy is very much suggestive. One is the CNS tuberculosis, because on the clinical suspicion, if you do not start the anti-tubercular therapy, patient may die. So this is a life-threatening condition, emergency. That is why with the sum of the evidence, if you get, in case of pleural effusion, I told do the ADA, even if required the repeated CBNAT, do the pleural biopsy. But CNS tuberculosis, even if you have some clue, you start the anti-tubercular therapy. Otherwise, patient will die. Neuroimaging often helpful, particularly the spectroscopy. Usually patient have the tuberculoma, basal exudate, hydrocephalus. These are very with a high lipid lactate peak. These are highly suggestive. The etiology of the presentation can be tuberculosis. And always remember, in CNS tuberculosis, exclude this differential diagnosis, particularly if the patient is immunocompromised. One is the cryptococcus meningitis, carcinomatous meningitis, and other bacterial or fungal meningitis. Abdominal tuberculosis, another challenge because of the accessibility, particularly if the patient have the rectoperitoneal lymph node or hepatic tuberculosis. Usually patient present with ascites, with hepatosplenomegaly, intestinal obstruction, doughy abdomen, and hepatic abscess. So usually this presentation is possibly in nature and have some difficulty in getting tissue except the ascitic fluid. That is why abdominal tuberculosis and particularly intestinal tuberculosis, to get the tissue from the intestine without any very expert gastroenterologist is a basically challenge. That is why, and the cirrhosis of the patient liver is commonly have the ascites and complicated with tuberculosis. Here usually if the exudative in nature and ADA is more than 29, it is highly suggestive of having the tuberculosis. This is the protocol, two basic nature. One is the abdominal TB, one is the hepatobiliary TB. Abdominal TB, omental thickening, multiple lymphadenopathy, low sac ascites, and if ADA is 29, better to start the ATD. If not improved by 4 weeks, then you go for the laparotomy and for the peritoneal biopsy. Hepatobiliary TB is one of the cause of PUO, there is a pyrexia of unknown origin. Patient usually have a prolonged fever. I do not get any clue from any imaging or blood or any other diagnostic modalities. But if you do the imaging, abdominal CT, you will get the multiple granuloma in the liver. That can confuse, that I told in the second case, that can confuse you whether the pyogenic liver abscess or tubercular liver abscess. So tissue biopsy is often needed by a expert pathologist, and one of the very important differential diagnosis, it should be hepatic tuberculosis, and others may be pyogenic liver abscess or malignancy. So abdominal TB, radio imaging is very important along with the endoscopy and colonoscopy. Now we are coming to the skeletal tuberculosis. In skeletal tuberculosis, just 5 minutes or 2 minutes. Skeletal tuberculosis, TB spine, tubercular osteomyelitis, tubercular arthritis, Ponsett disease. These are the very common presentation, and want to remember, this is the interesting case, the Ponsett disease, because patient often present with fever with arthalgia, and from the local arthalgia, this patient have a joint pain of the ankle region and getting the erectoma nodosoma. But from the locally, you will not get any AFB. But if you go for the very good clinical examination, you may get clue in some other places. You may get some lymph node in the mediastinum or lymph node in the neck or axilla or some other region, or may get some evidence of tuberculosis. Now, these are basically immunological phenomena. Due to presence of tuberculosis in any part of the body, there is a immunological phenomena in the joint area. Patient usually have the joint pain, arthalgia, and erectoma nodosum. This is the Ponsett disease. TB pericarditis is the last what I will discuss. TB pericarditis can present with pericardial effusion, cardiac tamponade, constrictive pericarditis. This challenge is the constrictive pericarditis. They are very common in these tropical countries because the patient often have the disease and do not get the treatment. Ultimately, pericardium become the calcified. So very difficult to get the fluid from the constrictive pericarditis because it is calcified. So protocol is, if the pericarditis calcification is the thickening is more than 4 millimeter, patient have other suggestive evidence of tuberculosis, you start the tuberculosis. But if there is no constrictive pericarditis, you can access the pericardial fluid, you go for the analysis of the pericardial fluid. If the ADA is more than 30, more than 40, in the start the antitubercular drug. But if the ADA is less than 40, you consider of the other etiology of the pericardial effusion. So I am not coming, last time coming to tuberculosis eye, is almost impossible to get the tissue. So this is another area where you have to depend on your clinical skill, your fundoscopic view, and you have to give the empirical antitubercular therapy for the disease. There is every organ can be involved in tuberculosis. It is almost a whole day seminar to talk about the extrapulmonary tuberculosis. Anyhow, 2 tests is mandatory for all TB case. One is the HIV, one is the blood sugar. So in summary, extrapulmonary TB can affect any organ and can be life-threatening. And diverse pathogenesis is responsible for the diverse clinical presentation. No single test is adequate to diagnose. You have to go for a battery of tests, and with your clinical judgment, you have to diagnose the patient as a tuberculosis. No single test or pinpoint diagnosis, culture positivity or AFB staining positivity many times may not be possible. So that is why high clinical index of suspicion is very much required of the physician to diagnose a case of extrapulmonary tuberculosis. Till even after 5,000 years, still that is why is a challenge to all of us. Lastly, before concluding, I invite all of you, our national conference will be held in my city, Kolkata, from 23rd to 26th January 2025. I invite all of you, please come. Thank you.
Thank you very much, Professor Joy, for sharing your expertise in diagnostic challenges in extrapulmonary TB. May I invite you to take a seat on the stage, please? And I think in the interest of time, I would also invite Professor Nandini Chatterjee also on the stage. So in the interest of time, we would be happy to entertain a single question. I would grab that chance from Professor Chatterjee. Now, now we see a lot of patients with joint pains and rashes. Can you just tell us few tips in diagnosing possible chikungunya, differentiating rashes of chikungunya from other viral illnesses?
Yes, this is a very nice question. Actually, there are, as I have mentioned, there are a number of infective causes which can lead to fever with joint pain. Now, as the dengue is very common and we have to mainly differentiate dengue from chikungunya clinically to suspect, then we have our investigations, of course. Now, the chikungunya rashes are pruritic and they are more concentrated on the trunk and the extremities, though some of the rashes may be in the face. And the main thing which differentiates it from the dengue rashes, because dengue patients, as you may have noticed, have a kind of red flushing in their body. And if you just press on their chest or on the skin, then there will be blanching kind of rash. This is not present in chikungunya rashes. The chikungunya rashes are more of a pruritic maculopapular rashes. Another point which is very significant is the arthritis, that is the inflammation along with pain in the joint. In most of the viral infections, we usually have joint pains. Arthritis is not so common. So if you have a patient with fever rash and actual swelling and redness and warmth of the joints, you keep that in mind. And thirdly, the investigations, as I have mentioned, that in others, like dengue, you may have a significant thrombocytopenia. It may happen in chikungunya, but never that way. And of course, the shock issue is there. It is not present in chikungunya. It may be there in dengue.
Make one comment. The chikungunya awareness is very important because chikungunya catastrophe or life-threatening, it is not a life-threatening disease. While a dengue is a life-threatening disease. That is why there is a lot of hue and cry for the dengue. Everybody, starting from government, from organizations, takes all discuss about the dengue, not chikungunya. Because chikungunya is often ignored because it has a fever with some joint pain, mortality is not high, almost nil, and the physicians and patient, they all ignored. But it is there are several studies that these patients have a prolonged arthralgia and ultimately become the rheumatoid positive. So that is why awareness of this disease is very important.
Thank you very much. In the interest of time, I think we need to conclude the session. I would like to thank both the esteemed speakers for sharing expertise, and may I invite Professor Tilak Jayalat to give away the certificates of appreciation on behalf of the Sri Lanka College of Internal Medicine. First to Professor Nandini Chatterjee. Next to Professor Jyotirmoy Pal.
Thank you, dear speakers and moderators, for that comprehensive session. We will now take a break.